We're waiting for Dr. Aib to join us. It start in 2 minutes.
Hello, Dr. Yusuf.
Hello. Sorry, I had some connection issues.
Okay. So, would you like to check your presentation?
Okay. To share my screen?
Yes, we can test
Yeah, okay.
if everything is good. Yes.
Can you see my
Can you
screen now?
make it not in full screen mode? If you can make it in full screen mode. Yes, now perfect. Yeah, that's good. We are still waiting for Professor Aib to join us. It's already in time. So, Ahmad, we can start, or should we just wait for 2 minutes, Dr. Aib? Yes, Dr. Aib.
Yes, hello.
How are you,
Hi.
Professor?
Absolutely good. Ahmed, how are you doing?
Yes, yes, I'm fine, Professor. Thank you for asking.
All good. I'm here. I'll be moderating. So we have our presenters already.
Yes.
Okay, right. Good. Go ahead. I'll let me know what you expect of me, and I'll be happy to oblige. So let me know. The presenters are Yusel and Mohammed and Amit, I suppose.
Yes.
Okay, right then. Okay, go ahead, please.
Okay.
Okay. Welcome everyone to our third webinar of the comprehensive neuroanatomy course, arranged and that coordinated by Yemen Neurosurgical Society in coordination with WFNS, Young Neurosurgery Forum, and the Neurosurgery Coach, and Walter Dandy, Yemen Student Club, and also the Neurosurgical TV, and also the Pakistani Society of Neurosurgeons. Today we have 3 presentations with the distinguished speakers. So Dr. Aib, please you can introduce the speakers.
Should I start my presentation?
Yes, Dr. Muhammad, you can start. Dr. Aib will
Okay, I'm sharing a screen.
introduce. Okay.
Okay, is it visible?
Yes, it's good.
Yeah, it is visible. Go ahead,
Okay,
please.
I'm Dr. Nawaz, head of Neurosurgery Department, leading hospital from Pakistan. We have a busy hospital and a busy department of 110 beds, in which we operate bone, brain, and spine, both type of procedures. Today, I'm going to present surgical anatomy of the nose, the notion nose for neurosurgeon. It's basically for the residents and for the beginners. Well, as all of we know, nose is a battlefield for the ENT surgeons. Basically, 1/3 of their surgeries and their field is in the nose, but it's an important gateway or pathway for us to navigate through the base of the skull. And a lot of procedures, endoscopic procedures like the pituitary procedures through transphenadal, endonasal, endosinus surgeries, and the extended approaches through the plantar and through down to the clivus to remove the cardomas, to remove tuberculum salamangiomas, and the rest of the plantar endolmeningiomas. All of them are through the endonasal endosinus surgery. And if I dig a bit more deeper, so we can give an example of CSF leaks, which we do repair via endoscopic endonasal approach. And nowadays, another approach is being getting popular, that is endoscopic endonasal optic nerve sheath fenestration through the lamina papyracea. So the crux of this whole discussion is that understanding the anatomy of the cavity or the landmarks of the nose is a navigation tool or Google Maps for us to go to the skull, base of skull, where we actually do the work. So this presentation is aimed at reviewing the relevant anatomy and basically reviewing the landmarks which will help us guide to the base of the skull. So the nose. As all of you know, nose is a pyramidal shaped structure which is beautiful and applied to the front of the face. Its tip is upward and the pyramid base is downward. It has been divided into the two cavities basically by a nasal septum, and it opens anteriorly via two openings, which is called nasal apertures or nasal nares, nostrils, and behind it communicates with the nasopharynx via large opening, that is the choana. So if you see the nose, some of these terminologies are important, like the area between this eyebrows is called the root, and the tip of the nose is actually the apex. Our residents get confused when we discuss it with them during our routine endonasal endoscopic surgeries. They take it as a common and they use layman terminologies for it. And this is the area is called the nares, and the dorsum of the nose is actually it's the bridge of the nose, right? So this is about the surface anatomy. Now coming toward the external structure and the bony structure of this nose. This pyramid is actually osteocartilaginous framework, which is covered by muscles and skins. Basically, if I sum up and summarize, it's upper 1/3 of made up of bone, while the lower 2/3 is of cartilaginous framework. The bony part consists of two nasal bones, which meet in the midline, and the rest of the upper part of the nasal processes of the upper part of the nasal process of the bones. Like if these two bones are the nasal bones, and these are joining here, the nasal processes of the frontal bone. And on the bones, both sides, if you can see, the frontal processes of the maxillary bones hug it. So these are the four bones which make the 1/3 of the nasal cavity. And the cartilage part is the 2/3 of the cartilage, which make the rest of the nose. Well, each nasal cavity consists of a skin-lined portion, which is the vestibule, which is anterior, very small portion. And the mucosal lined portion is actually the nasal cavity proper. So we can divide the nasal cavities, each cavity into the nasal cavity proper and nasal that's the vestibule, which is covered by skin. So if we go to the discussing the nasal walls, as it has already been discussed, a pyramid which has a roof and a floor and lateral walls, right? So the roof, if I can describe it, it has a sloping roof and the horizontal roof. The sloping roof in anterior 2/3, it's a cartilaginous roof, and in the posteriorly, it's made by the sloping, it's by the nasal bones, which join in the midline. And this posterior part of the middle part of the frontal this horizontal roof part of the roof is made by the ethmoid, the cribriform plate of the ethmoid bone, which of course have olfactory nerves pierced through it 10 to 12. Okay. Now I have to. Okay. Now we have to discuss the floor. Like it's the floor is formed by the palatine bones and maxillary palatine process of the maxillary bones, and the small portions are contributed from these surrounding bones, like this is the sphenoid and rostrum and the ethmoid spicules. They take part of that, but the major quadrangular part is actually made by this septal cartilage. And if we come down here, so part of the septum is actually membranous type, which is basically double side of the skin and some connective tissue. So if I sum up this septum, it has three parts. One is the columellar septum, which is formed of columella containing the medial crura of the ala cartilages united together by fibrous tissue and covered on either side by the skin. Like this is the most anterior part. And behind this columella, we have this membranous septum, which is consisting of double layer of the skin with no bony or cartilaginous support here. And it lies between the columella and the septal part of the cartilaginous part of the septum. And then behind we have this cartilaginous part of the septum, and then we have this bony part of the septum, which is perpendicular plate of this ethmoid bone and the vomer bone and the spicules of the surrounding bones, which form this septum. Well, on endoscopic view, we don't see all these bones and all this. What we see in endoscopic view, we see hair, skin with the hair follicles and hair, lot of secretions here. And then behind we see mucosa, which is in the lower 2/3, it's a pinkish color, and in the upper 1/3, it's a bit pale colored, which is actually the olfactory mucosa. Basically, the lateral wall is more of our navigation tool, because it has many landmarks and it guides us through the whole nose cavity to the base of the skull. So the lateral wall landmarks are very important. There are 3 or occasionally 4 separate the bony projections, which is actually called concha or turbinates. Like if you can see here, it's inferior turbinate and the middle turbinate and the superior turbinate. And sometimes in some cases, there is another 4th one, that is the supreme turbinate. The space behind this or beneath this turbinates is called myitis, which is actually the space where the nasal sinuses or various openings are there, like in inferior turbinate, inferior meatus, the nasolacrimal duct opens, which is covered by a famous Hasner wall of mucosal, and the middle turbinate, which is having the openings of the maxillary sinuses and sometimes the accessory maxillary sinus opening, and the middle ethmoidal air cells open in the as well here. When we come to the superior meatus, so frontal sinus opening here is in the superior meatus, and just medial and behind here we get the sphenoid sinus ostia. So if I discuss it a bit detailed, I think middle turbinate should be discussed because it has a bit complex anatomy. Middle turbinate is the part of actually ethmoid wall, and it is attached to the lateral wall by a bony lamella. We will be navigating through this via endoscopic video, but it's just for the sake of basic discussion. It is attached to the lateral wall by a bony lamella or ground basal lamella, which is it is termed like that. It is actually S-shaped attachment. This attachment need to be discussed because somehow when we outfracture it in the endoscopic endonasal surgeries, so it might cause CSF leak. So it is important to discuss. Initially, we were not understanding why it is getting a CSF leak, but in its anterior third, it's at S-shaped attachment, and in the anterior third, it lies in the sagittal plane, and it is attached to the lateral edge of the cribriform plate. And the middle third, it lies a bit in the frontal plane, and it has attachment with the lamina papyracea. And in the posterior third, it has some attachment with the lamina papyracea and medial wall of the sphenoid sinus. So the meatus of the middle, this turbinate, it has some landmarks which are important for ENT surgeons and of course for us as well. Here, the blue structure which you can see it's a hook-like structure which is called uncinate process. It is important because if you can see just behind it, below and behind it at lower end, here you can see an opening, and it is covered by just mucosa, and the ENT surgeon pierces through it and go through to this maxillary sinus. And the structure behind this uncinate process, there is elevated projection, and which is called bulla ethmoidalis, which is maybe a pneumatized structure or solid bony prominence depending upon pneumatization. Between these two structures, we have a shallow depression or a cleft, which is called hiatus seminolaris. And at the lower end of that is the opening of this maxillary sinus opening. Above and behind of this bulla ethmoidalis, we would be able to see in the video, there are spaces like the suprabullar space and retrobullar space, and which combinedly are called the recesses together called lateral sinus. And this sinus is bounded superiorly by the skull base, laterally by the lamina papyracea, and medially by the middle turbinate, and inferiorly by the bulla ethmoidalis. And it's probably the landmark for doing the optic nerve sheath fenestration through lamina papyracea. I haven't experienced yet. Okay, as I have discussed, it has opening of the maxillary sinus and or accessory opening and middle ethmoidal air cells opening. The superior turbinate, I have already discussed, is situated superior and posterior and superior to the middle turbinate. It forms an important landmark to identify ostium of the sphenoid sinus, which lies medial to it. The superior meatus is a space below the superior turbinate, and which houses this posterior ethmoid air cells open into it, and sphenoethmoidal recess is actually located medial and superior to the supreme or superior turbinate, and it gives us the landmark of the opening of the sphenoid sinus, which is very important in opening the sphenoid sinus. Very brief about the blood supply of the nose. Basically, it takes blood supply from the internal and external both carotid arteries. The internal carotid artery supplies through the ophthalmic division and then division into the anterior and posterior ethmoidal arteries. And the external carotid artery, it provides the major blood supply to the nose, both the septum and the lateral walls. And basically, it's two divisions, two branches, the facial artery and the maxillary artery supplies it. The facial artery contribution is less, but the maxillary artery basically has more contribution to the blood supply of the nose. And it is by two branches, that is, one is through the lesser palatine and greater palatine for the majority of the palate area, the floor and the lateral wall. And through sphenopalatine artery, it supplies the septal area and the rest of the nose. And this is majorly important. The sphenopalatine artery is important because we make the nasoseptal flap based on this sphenopalatine artery. And when we do dissections in the vicinity of the sinus, usually this artery bleeds and gives a big headache to the surgeon. Okay, nerve supply of the nasal cavity, it has three types of nerve supply. Like, obviously, it has olfactory nerve supply for the olfactory sensation, which is through the olfactory bulb, and 10 to 12 or 12 to 20 nerves pierce through this cribriform plate and supply this area. And interestingly, it may carry sheath of dura, arachnoid or pia with them. And sometimes even not by not injuring the cribriform plate, by just injuring these mucosa might cause CSF leak because of this these nerves carrying the pia and this dura and arachnoid with this these nerves. And a part of the olfactory nerves, we have other types of nerves, that is nerves for the common sensation, tactile sensation, or other sensation, and autonomic nerves. The nerves of the common sensation, there are many names here, probably may not be important for us, but one thing which is important, that all of these nerves from the branches are the branches of the trigeminal nerve. The upper third is supplied by ophthalmic division, the middle third of the nasal cavity by the maxillary division, and the lower third by the mandibular division. Autonomic nerves are both sympathetic and parasympathetic to the nose. This is important. If we could see, we usually get this radiology, and if you can see, a lot of details is there in the city. If you can see, this is the sphenoid sinus, and which has septum, which is in the coronal plane, and it has hyperpneumatized ethmoidal air cells and the frontal sinus, and it is attached or communicated with the ethmoidal cells. Here, if you can see in the nasal cavity, this is like, if you can see here, it is the bulla ethmoidalis. This one is the bulla ethmoidalis, and this space is this is hiatus semilinaris, and the middle concha can be represented here. This is the bridge of the nose and the cartilage, and this is the floor. The nasopharynx can be seen here, sphenoid sinus, and this is the clivus, the skull base, the cribriform, all area which can be seen. It's a bit lateral view, it's not in the midline, so cribriform probably is not visible here. This is what is more of our interest. It will be more presented in the next presentation. But for it is related to the videos which we are going to discuss and further. So we are seeing here. As you can see, it's an inside view of the base or the of the sphenoid sinus. Here are some impressions which are of surgical importance. The topmost here is the optic nerve impression. Here in the midline, here is the optic chiasm, and on the lateral there is optic nerve. And these impression on both sides here and here, actually internal carotid artery impression. And the lateral OCRs, lateral opticocarotid recess, here is visible. The medial OCR is not visible in here. And here the bone has been taken up from the floor of the sella, and the dura mater is visible. If you go up here, so we go into the anterior skull base, and it's a planus sphenoidal area for extension of the transsphenoidal surgery. And if you come down here, so we can come to the clivus. It's unlabeled. Another view, as you can see here in the optic impression, this is the planus sphenoidal area and the chiasma here, lateral OCR, the carotid impression beautifully shown here, and the clival area, the pituitary fossa, medial OCRs are visible. Here is endoscopic view. It's the right nostril endoscopic view. As you can see here, this is the lateral wall. This is the medial septum. Probably some DNS here on the right side. And you can see here, this is the middle turbinate and this is the inferior turbinate, the meatus of the middle turbinate, and this is the nasal cavity proper between this middle turbinate and the septum. And now we will be going to the choana. As you can see here is the choana, and this is the opening of the station on the right side. The first pass which we do in the endonasal transsphenoidal surgeries. This is the lamella of the attachment of S-shaped attachment of the sphenoid sinus. This is a middle turbinate. I will go to this next slide. It's again the right nostril and a bit here. It's a clear view. As you can see, the uncinate process, and behind it is the bulla ethmoidalis, and the space behind. You can see this beautiful space between the bulla ethmoidalis and this is the hiatus seminillaris, and we can go behind the bulla ethmoidalis for retrobulbar space, and here I can show you this suprabulbar space. I wish I could see entry into the lamina papyracea. It is somewhere here. Up and above. It's going up in a second. Okay, so we are in the meatus of the middle turbinate. Now we are coming out and going to nasal cavity proper, pushing the middle turbinate laterally, and this is our septum. We are going in the cleft, narrow space, potential space, and dilating it to reach. Actually, we have to find now the superior turbinate. This is superior turbinate, right? So by pushing this middle turbinate and now pushing this superior turbinate, we are able to see, yes, this sphenoid sinus ostia in the sphenoethmoidal recess. And now we will dilate it to look inside view of this sphenoid sinus. So this is all about the navigation through these landmarks, and relative knowledge and of the anatomy of all these landmarks guides us to reach to this point, and our work starts from here. The next video is a bit detailed dissection of inside of the nasal cavity, and in this video, we will be seeing the dissection through the left nostril and the right nostril, and the entire nasal septum from the cartilaginous to the bone will be taken, and both cavities will be communicated, and the clear view of the entire anatomy of the both lateral valve and the sphenoid sinus view will be visible. Here, at the start of the video, he takes the nasoseptal flap as well, luckily in dissection. So it's, as you can see, it's a first cut from superior 1/3 and inferior 2/3 junction. It's coming straight down at the cartilage and bony junction, but probably he's doing a bit proximal because for the sake of dissection, he's elevating this mucosa. It's being peeled off. Nasoseptal flap, as we all know, it's required for us while we are performing CSF rhinorrhea repairs, and if we are operating on the pituitary and we are expecting we need to repair this sella floor, so we make nasoseptal flap and place it in the choana as we usually do it here. Now, after elevating, he's giving a second cut at the junction of the superior 1/3 and inferior 2/3, all the way posteriorly up to the keel, right? It's a bit 7-8 minutes video. It's very good to understand the basic navigational anatomy through this nasal cavity. Now he will be giving this last cut at the base of the septum and push it backward into the choana on the left side. We are working on the left side here. Yes, now it's being pushed in the choana. So this sphenopalatine artery branches is the sole blood supply to this nasoseptal Haddad flap. I hope it's not getting lengthy. So now this cartilage is being taken to elevate mucosa of the right side, and here he takes it so well, exposes the rostrum through this tunnel. I usually follow this, and I expose the rostrum and make entry through the rostrum into the sphenoid sinus, because it's a more consistent landmark and takes us to the middle of this sphenoid sinus. So the cartilage and the bone of this entire septum will be taken. Then the opposite side of the mucosa will be taken, and the whole of this nasal cavity would be made in the single room, and then the sphenoid sinus anatomy and everything would be visible in a proper navigated way. So as you can see, here is the mucosa of the left side of the nostril, and on the right side we can see the that is the right side of the nostril and mucosa, and on the left side we have the lateral wall of the nasal cavity. And this is the rostrum, which you can see. Now, when mucosa from the right side will be taken, the anatomy will get a bit clear. So now it's through the right nostril now. This cuts into the mucosa of the right nostril by cutting and removing it. It's an anatomical dissection, basically, not a surgical procedure. There you can see this sphenoid sinus ostia, which is visible. And this all mucosa is being taken down. Here we go. So now on the both side turbinates, superior turbinates, middle turbinates are visible, and this is the rostrum in the midline. And both ostia visible here. Okay. Here now, the sphenoid sinus is opened, the rostrum is taken. Here you can see the keel. This is a nice view of the sphenoid sinus. I hope it will be discussed in the next presentation with full detail. But navigating to this is the goal of this presentation. So, yeah, the septum in the sphenoid sinus is being taken, which is ipsilator on the left side. And it's all. Thank you for your patience. Thank you.
Excellent, Mohammed. Excellent presentation. That's very exhaustive coverage of the nose as it is needed. You know, I mean, I would have expected nothing less from you. So I know about the great work that you guys are doing in Pakistan. And at the end of this presentation, maybe I can do a 3-minute video on some of the new trends that we do. For example, brainstem tumors through the nose, or aneurysms through the nose and things like that. So we, and plus some, maybe 1 or 2 giant pituitary tumors where we advocate subdiaphragmatic dissection. So maybe at the end, I can show for about two or 3 minutes. But I guess we have a very exhaustive presentation this way. So the next speaker would be, I don't know how to pronounce this, Yücel Dogruel.
Yücel Doğruel.
Yeah, okay. So Yücel